Well, hello and welcome to this month's podcast, where we're going to bring you up to date with the latest information and data in the world of rheumatology. And what a wonderful world that is. Now, joining me today are two fellow members of the IMID Forum Steering Committee. Our first guest is Hideto Kameda, who's Professor of Internal Medicine at Toho University in Japan. And our second guest is Rieke Alten, Head of the Department of Internal Medicine, Rheumatology, Clinical Immunology, Osteology at Charité Universitätsmedizin Berlin, Germany. Apologies to you both for making such a terrible business of pronouncing your beautiful home cities, but lovely to have you joining me for this podcast today. Welcome to you both.
Yeah, hi, Iain and Rieke.
All righty. Well, today we're going to be reviewing papers by famous people, by Ronald van Vollenhoven and Roy Fleischmann, in which the long-term efficacy and safety of upadacitinib was examined over 5 years in select early and select beyond trials. Now, as always, to access detailed summary slides for the papers discussed today, please go along to imidforum.com. imidforum is all one word, .com. Now, the first paper, upadacitinib monotherapy versus methotrexate monotherapy in patients with rheumatoid arthritis, efficacy and safety through 5 years in the select early study. So look, Hideto, why don't you take us through the background and the key findings for this one? Over to you, sir.
Okay, Iain. The upadacitinib is a JAK inhibitor for the treatment of rheumatoid arthritis. The select early trial focused on methotrexate-naive patients with moderately to severely active rheumatoid arthritis, randomizing them to receive upadacitinib 15 or 30 mg or methotrexate. The trial's objective was to assess the long-term efficacy and safety of upadacitinib monotherapy compared to methotrexate monotherapy over 5 years. Participants were allowed to receive background non-steroidal anti-inflammatory drugs, acetaminophen, and glucocorticoid 10 mg per day or less. Patients who did not achieve CDAI remission by week 26 received rescue therapy, namely addition of methotrexate for the upadacitinib group and addition of upadacitinib for the methotrexate group. And efficacy outcomes included CDAI remission, disease activity score (20-SCLP), and ACR response criteria, with key assessments conducted at week 260, namely 5 years. As results, higher proportions of patients on upadacitinib monotherapy achieved disease activity targets compared to methotrexate at week 260. Indeed, 53% and 59% of patients on upadacitinib 15 and 30 mg respectively achieved CDAI remission, compared to 43% on methotrexate. Upadacitinib 15 mg and 30 mg also led to greater inhibition of joint damage, with 87% and 86% showing no radiographic progression versus 70% on methotrexate. In terms of DAS20-SCLP remission less than 2.6, 78% and 81% of upadacitinib 15 and 30 mg patients achieved this threshold, compared to 60% on methotrexate. And ACR 20-50-70 responses were more frequently attained with upadacitinib over methotrexate at week 260. Namely, upadacitinib 15 mg achieved 93, 84, 73% response rates for ACR 20, 50, and 70, respectively, compared to 90%, 79%, 61% for methotrexate as observed. Upadacitinib 30 mg had higher rates of exposure-adjusted adverse event rates per 100 patient years compared to the 15 mg dose and methotrexate. And serious infections neutropenia, and herpes zoster were more frequent in the upadacitinib 30 mg group. In conclusion, over 5 years, upadacitinib demonstrated superior efficacy versus methotrexate in achieving disease activity targets, including CDAR remission, DAS28, and ACR responses. Higher doses of upadacitinib 30 mg were associated with greater adverse events, particularly serious infections and neutropenia, although most were manageable. The 15 mg dose of upadacitinib provided a favorable balance of long-term efficacy and safety for methotrexate-naive patients with rheumatoid arthritis. These findings highlight upadacitinib as a valuable monotherapy option for achieving better clinical outcomes in rheumatoid arthritis, especially when methotrexate is not tolerated or effective.
Yeah, thanks, Hideto. That was a great summary. Rieke, I might just bring you in quickly before we go on and think about actually quite a similar analysis, but with patients further down the line. I always struggle with these 5-year efficacy data sets. You know, they're as observed, and Hideto made that very, very clear. You know, I think the efficacy comparison needs to be made in that earlier time frame when the trial is designed and powered. Any thoughts on that? Because you know, when you read ACR response rates of 90%, 85, 84%, you think, whoa. But I think it's just important to qualify that. Is that a fair comment, Rieke? Any thoughts?
Actually, you always have to take into account the number of patients who stayed in the observational period over 260 weeks, because we have to see that I think around 45% of the patients who were randomized are still in the trial at this time point. But this is normal, this is not low. And actually, we have to understand that I like these long-term trials, especially for safety. That is my point, which I think they should be done. And here we actually see the same, I think.
Yeah, no, I couldn't agree more. And I think, I mean, Hideto, you did a beautiful job in just crystallizing exactly what we can see. I suppose I'm not particularly surprised that 30 milligrams of upadacitinib turned out to have more events than 15 milligrams. I think the real concern, of course, we have after oral surveillance is what 15 milligrams of upadacitinib looks like against, for example, methotrexate, or probably more reasonably, and we'll come to that in a moment with Select Beyond. You know, what is the real comparator? I don't know. Again, we've asked Hideto to do lots of work. What are your thoughts there? I mean, it's really the 15 milligram dose that we're interested in, isn't it?
Okay, so I think that it depends on the population. So for overall rheumatoid arthritis population, then 15 milligram may be the best option. But when we consider some very limited population or excluding some safety concern patients, then it may be different. And also we see that in other populations, such as inflammatory bowel diseases or so, it is totally different. So we usually start at upadacitinib 45 milligram, and that is the best option for induction therapy. So it depends on the population.
Now that's really, Rieke, do you want to comment? Because I'm quite keen. We'll move this discussion on in a moment. But any final thoughts on the monotherapy comparison study?
Actually, concerning the dosage, we always have to realize that our RA population is really vulnerable in many aspects. And that leads also to the conclusion that we cannot compare this population to the IBD population because they are younger, they have a different autoimmune profile, etc. There are many thoughts on this. So actually, yes, I think 15 milligram for the patients with rheumatoid arthritis, as in the label, is correct.
Yeah, absolutely. So I guess to those listening to the podcast, really interesting paper. Very clear presentation today, so thank you for that. But make sure when you're reading the paper in retrospect that it's really the 15 milligram dose that you zone in on. That's the arm that really matters in terms of clinical practice. Well, look, that's kind of, it's in the title, select early. What about those patients who've already had a trial of therapy and are a bit further down the journey? So, Rieke, maybe you could talk to us about the Select Beyond study, if you would be kind enough. Thank you.
Thank you. Actually, this population is really more difficult to treat. They have already experienced, let me say, one TNF or whatsoever. And we know that these patients, and I saw some of these today already in my outpatient clinic. And anyway, the long-term safety profile, I do not go to efficacy so much, but at least a little bit. The long-term safety profile was evaluated concerning infections, which is very important in the 5-year round, also mortality. And over 81% of the patients receiving upadacitinib 50 milligram achieved CDAI low disease activity, compared to 69 for the placebo group. This were the group treated with conventional CSD MADs. And if you go to DAS, which we don't do so much anymore, there we had figures coming below 3.2 to 75% of the patients. The ACR response rates were okay, where for ACR 20, 80%, for 50, 68, and it's like standard 50% for ACR 70. Boolean remission was achieved by 28% of the patients on 15 milligram versus 22 milligram of the 30 milligram group. And this is not really a radical benefit over the 15 milligrams. So coming to AEs, of course, it was higher in the 30 milligram group. There were 354 events in the group with 30 milligrams compared to 274 events per 100 patient years in the standard group with 50 milligram. The same is true for serious infections. Again, for the 30 milligram, it was really much higher. And what is always in our focus is the herpes zoster. We see less herpes zoster since we regularly do vaccinate. And as you know, in Germany, it is reimbursed, fully reimbursed by the insurance. So here, the 30 milligram had 7.4 events per 100 patient years compared to 3.8 events in the 50 milligram group. And this is really an important figure, I think. And fortunately, we are not so much to make the decision by ourselves to give our patients 30 milligrams. I had a dentist recently, and she was not so happy with 50 milligram, so she gave herself the double dosage, but this is typical a doctor. Fortunately, she talked to me about this, and then we could stop it again, and she had no really severe adverse events. So coming to an end, the 5-year treatment with upadacitinib in those patients who had already experienced other biodrugs showed a good efficacy with high proportions of patients achieving clinical remission or at least low disease activity. The safety profile remained consistent with all what we saw before from the shorter duration of the trials. So actually we can conclude that 15 milligrams upadacitinib give us a value treatment option for our patients who had already experienced TNF or other biological DMARDs with good efficacy and also a manageable safety profile. And at least as we always have the discussions with our patients on safety, and even yesterday I was contacted by the German TV to give something on the EMA decision, and actually you have to be very prudent. He wanted to see patients who were, we have the checklist in Germany, and we put this checklist to all our patients. And my experience last year, when I counted, I had only 2 patients of 200 on JAK inhibitors who had to stop. But we have to be very, very cautious with the rumors after the oral surveillance paper. And so I gave him a negative decision I do not want to show in TV next week, because I think it really still has to be managed by us, by ourselves. So we have new data, we have good data on the 5-year observational period. And I think these data are also confirmed by our registries like the RABBIT or the BSBR. So that's all in line. So I feel confident to treat my patients with UPA.
Yeah, thank you, Rieke. That was terrific. And by the way, I really appreciate your remarks around the value of real world evidence, as well as, of course, randomized control data. And also this idea that long-term extension of an RCT is quite often not controlled all the way through the long-term extension. And that's where people can run amiss. So a couple of things I want to maybe pick out. The first, actually, Hideto, if you don't mind coming to you. Whenever I think of herpes zoster, my mind always goes to Asian populations. Perhaps you could share with us your perspective on the risk of zoster for upadacitinib, for that matter, actually the JAK inhibitor class. So maybe just your top line thoughts to guide us, because I think you probably see this more than any of us.
Okay, thank you. So in Japan, we have a data of selected sunlight study. So it's a CS demons IR patient, and we prescribed 7.5, 15, and 30. And we can see very clear dose-dependent development of herpes zoster. So 7.5 milligram, the least, and 30 milligram, the highest. So we can see very well dose dependency for herpes zoster, but we could not see clear dose dependency for MACE events or malignancies. So it's totally different. So for herpes zoster, upadacitinib or other JAK inhibitors affect indeed for the development of herpes zoster, but it is not clear for other adverse events, for example, MACE or malignancies. So that is a clear difference between zoster and other adverse events.
Yeah, thank you. And I think that point, this differentiation across dose, I want to just make a couple of remarks of my own about this. I think it's really, really important. So one of the things we always have to remember about JAK inhibitors is that as the dose increases, so the absolute selectivity of these drugs is reduced. And so I think it's quite likely that when we get to 30 milligrams of upadacitinib, some ex vivo functional analyses at least would suggest that it's not as JAK1 selective by that stage. And so I think what we're starting to see is the biology playing true. We get cytokine inhibition across more pathways. We start to see inhibition of effective defense mechanisms that allow the elaboration of what we're seeing, which is higher infection rates, manifest in general serious adverse events, actually, but also in viral recurrence events. So I think it's a really useful reminder that these drugs are potent, broad spectrum cytokine inhibitors, and we've got to be very respectful of the dose. Even I love, Rieke, your example, physician heal thyself, but not with JAK inhibitors. Always do what the other physician tells you. I think that's a great story. So look, what a wonderful discussion. As always, I have learned a very great deal. Thank you, Rieke. Thank you, Hideto, for sharing your time and your knowledge and your expertise. And to those of you listening to the podcast, if you want to look at the publications uploaded this month, and of course, to access all of the other podcasts and resources that are in there, head over to imedforum.com. It is a veritable treasure trove of fantastic resource. Abstracts, summaries, slides, podcasts, happy, smiley academic faces. What more could you want? All in one place, imedforum.com. And don't forget to subscribe to the Immune-Mediated Inflammatory Disease Forum podcast channel to make sure you don't miss our podcasts in the future. And as always, make sure to let us know what you think by leaving a review. But most of all, thank you for your attention. I really hope that this podcast and the information contained has been useful to you in looking after the people who matter far more, our patients. Thanks ever so much. Stay well.